Well, hello, and thanks so much for joining me today for episode 11 of season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to again begin today by thanking the SCAN Group for funding and supporting this podcast. And actually, big congratulations are in order because the SCAN Health Plan, which is within the SCAN Group portfolio companies, earned 4.5-star rating from Medicare today for the 5th straight year. This is very impressive. The only California health plan to rank this highly for 5 consecutive years. I'm very proud to be affiliated with the organization. As a reminder, I work for Healthcare in Action, which is also part of the SCAN Group portfolio of companies. And my views are my own, not reflective of SCAN or Healthcare in Action or any other SCAN Group portfolio companies. So today we are going to cover a important topic to being an educated and engaged medical consumer, but it's not always the most fun topic. It's statistics. And my guest today is a primary care physician, my brother, Dr. Stephen Hochman, who's going to try and distill it in an understandable and hopefully fun and engaging way. So please do stick around for that. If you do find today's episode enjoyable, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to friends, family, and others who might be interested. Leave a review if you have a chance. And also a reminder, we are on YouTube. Search Healthy Skeptic MD on YouTube and subscribe there as well. Okay, so before we jump into our interview with Stephen, there are 2 health news items that I want to touch on first. And the first is an article that I read this week in The Atlantic. I think it is the best encapsulation yet of my perspective on where we stand with this pandemic at this time and my views on it. It's written by a primary care doctor, Dr. Lucy McBride, private practice doctor in Virginia. I've never met her, but she's written an excellent COVID newsletter throughout this pandemic. So if you search for Lucy McBride, you should have no problem finding her newsletter. It's gotten a lot of attention. The article is called The COVID Serenity Prayer, and it's a description of her experiences being a primary care doctor and dealing with her patients about the pandemic over the last year and a half. And I want to read you a couple passages from the article. So the first thing she writes is the 2 things that patients have wanted from me during the pandemic are reassurance that they won't get COVID-19 and permission to engage in life. I cannot deliver these, and I never will be able to. SARS-CoV-2 is here to stay. The virus will be woven into our everyday existence, much like RSV, influenza, and other common coronaviruses are. The question isn't whether we'll be exposed to the novel coronavirus, it's when. And although many of us will inevitably get COVID-19, for the majority of vaccinated people, it won't be so bad. The vaccines weren't designed to wholly prevent COVID-19. They transformed it into a manageable illness like the flu. That means from a decision-making perspective, we've started to reach the acceptance phase of the pandemic, a time when we must recalibrate our individual risk gauges, which have been completely thrown out of whack. The approach I'm embracing with patients boils down to a secular version of the Serenity Prayer. We need the serenity to accept the things we cannot change, courage to change the things we can, and the wisdom to know the difference. She then goes on to say, to be clear, reopening society once the coronavirus is deemed endemic does not mean jettisoning public health measures that obviously benefited our most vulnerable populations. Rather, we can all participate in sensible infection control measures, such as hand washing and staying home when sick, to reduce the spread of all airborne viruses that pose more danger to high-risk people. Acceptance is not about agreeing with or surrendering to suffering. It is not about reckless abandonment of caution or carelessness towards others. It means letting go of the false promise of COVID-0, taking an honest assessment of our personal risk tolerance, and ceding control where control isn't possible. It's about getting vaccinated against COVID and the flu before attending a wedding in person instead of watching the nuptials on Zoom. So check it out, the COVID Serenity Prayer in The Atlantic this past week. Really great article, and there's much more than what I covered just there. Okay, so the second news item I want to touch on a very different topic are new federal guidelines that may be coming out soon about the use of aspirin for those at risk of heart disease. So for those who previously have had a history of heart attack or stroke, it's generally recommended to take an aspirin. But aspirin is also recommended in those at high risk for cardiovascular conditions. So the current guidelines recommend aspirin for adults 50 to 59 who do have risk factors for cardiovascular disease, and it also recommends consideration of aspirin in those 60 and older with high-risk conditions. The new guidelines call for a significant scaling back of these guidelines. So first off, they actually recommend against the use of aspirin in those 60 and over who have not had a previous history of heart attack or stroke for the simple reason that the risks of aspirin outweigh the benefits. That's a very significant change. And it also recommends only using aspirin in special cases, basically those at high risk, for those in the 40 to 59 age category. And you should, of course, consult your doctor to consider whether you fall into one of those categories. These are just draft guidelines, so we'll see if they end up being approved, but certainly if they are, this would recommend a very significant change. And it's just another example of really the evidence catching up on a medical service that is not proving to be as effective as we initially thought it would be. And if you want to know about a similar case, we had a really good episode about 3 months ago with Dr. Rita Redberg about the use of statins at those at high risk for cardiovascular disease. And there's a lot of similarities between these two situations. That's it for the news summary. Let's jump into our interview with Dr. Stephen Hochman. Well, welcome back to the Healthy Skeptic MD, Dr. Stephen Hochman.
Thanks so much for having me. Never like to timestamp our recordings, but we've got ALDS Game 4, and we're watching the Red Sox. So if I seem a little distracted, just got my eye on the game cast.
You got to get your priorities straight.
No, of course. It's a pleasure to be here with you, and I'm really excited to have this discussion today.
And Stephen is right that we are recording this in the middle of a baseball playoff game, which is very, very important to Stephen and also to me. But hopefully we'll get a good outcome when we finish. And I also will mention that this is your fourth time on the Healthy Skeptic MD, backed by popular demand, mainly Mom, but nevertheless, you're back.
Yep, racking up those credits for my IMDb page. So very excited to be back, and I've enjoyed doing it the first 3 times, and hopefully we can have some fun and get some stuff hashed out this time as well.
All right. Well, we have an interesting and unique topic to talk about today, which is medical statistics for consumers of medical services. And I think it's straightforward why we doctors need to understand a little bit about epidemiology and statistics, but why do patients need to understand a little bit about statistics?
Yeah, well, I think my answer to this one is going to be a bit cheeky because I really think everybody needs to have probably a slightly better understanding of statistics than they do. To give sort of a silly example, if you decide to go to the store to buy yourself dinner, you're doing a statistical risk of weighing the risks of starving to death if you don't buy yourself food versus the risk of getting hit by a meteor or something on the way there. So really all day, every day, we are doing statistical assessments that are really important. For instance, more pragmatic, maybe going back to school to get a degree or deciding to have a child, there's an upfront cost and then there's a reward at the end, the reward of parenthood, or maybe you get a raise at your job or a new job. And so those are all statistical decisions that we're making, and really medical decisions are no different. Every time I prescribe a medication, there's a risk of side effects and there's benefits, and we're trying to weigh with the patient what makes the most sense, and the only way to do that is sort of with a good understanding of how the numbers play out.
Yeah, it's interesting the way you described that. It actually reminded me of what my college econ professor used to say. She used to say, life is a risk. And sometimes, patients will ask you all the time, is there a risk of this treatment? Is there a risk if I do this? Well, yeah, there's a risk, but there's also a risk if you don't do it. And, we're all forced to make calculated risks, and we want to use the information we have to make the best decisions we possibly can. Can you give us some examples of how consumers can be misled?
Absolutely. I think individual risk is really hard to wrap your head around, especially for things that happen rarely. And in medicine, even common things happen fairly rarely. So the example that pops into my head would be, maybe a 55-year-old guy takes medicines for blood pressure, but otherwise healthy. And you look at his 10-year risk of having a heart attack or a stroke, a fairly common outcome, and it's 5% or 1 in 20. And I think when people first hear 1 in 20, it has a very intuitive meaning. But then when you really think about it, well, what does 1 in 20 really feel like? What does it really mean? And if we even take that a step further, what about something that happens 1 in a million times or 1 in 100,000 times? Those are numbers that are just really hard to comprehend. And so I think consumers can be misled just by understanding exactly what the scale of their risk is. I think the other thing that makes it real challenging is individual bias. If your lifelong friend has a sudden heart attack and dies, that your internal thermometer for risk is just turned up. This applies to patients. It also applies to doctors. If you're a cardiologist and all day, every day, you're going into the hospital and seeing people with terrible cardiovascular disease, it starts to feel like it's way more common than it really is. So that can be really confusing. And I really think the cherry on top for medical risk is just how complex a single medical decision can be, because it's not just a simple what's the risk of the disease, what's the risk of the treatment. There's the risk of the treatments, but there's more than one. They all have different risks, and also benefits of treatments. How much benefit you get, how much pain gets cured, how many heart attacks get prevented. These are things that mean different amounts to different people.
Yeah, the bias piece is really interesting. A lot of times patients will say, I have a heart condition, I need to see a cardiologist. And, at first blush, that may seem like it makes a lot of sense, but cardiologists are the ones who see heart attacks every day, and they are biased and skewed in that direction. It's the same reason why we have a civilian-controlled military. Obviously we want military leaders to be very involved in decisions about whether or not to go to war, but you want people who are actually not doing it making those decisions. In the same way, if you have a heart condition and you want to know whether to get an intervention, sometimes you actually want to get an outside perspective from the primary care doctor or even someone who's not involved in medicine at all. But I did want to pick up on the issue of risk. So sometimes like a drug company will say, this medication will reduce your risk by 30%. Why can that be misleading?
Yeah, so these types of claims about relative risk reductions are incredibly common. And what a relative risk reduction is just like it sounds. It's how much does the risk you started with change with their intervention. And it might seem obvious, but in order to properly interpret a relative risk, you need to understand your own starting risk. So, for instance, as an example, if someone walked up to you and just said, I'm going to give you half the money in my pocket, that would be a 50% claim, but that is a very different claim if they're carrying $5 versus, say, $1,000. Maybe we're talking the difference between a down payment on a car and buying a Starbucks coffee. So just knowing you're going to get half of what they have doesn't give you all the information you need. So taking a really common example that comes up in my practice all the time would be using cholesterol-lowering medications called statins to treat heart disease. What we know pretty well is that a statin will lower your risk, a relative risk reduction of about 20%. But let's look at two different patients and what that means to them. First patient, maybe a man in his 70s with high blood pressure, diabetes, a smoker, probably has about a 30% 10-year risk of having a heart attack or a stroke, and a 20% risk reduction from a medication is a 3 or 4%, a 5 or 6% reduction in his risk, which is a fairly significant reduction. Now, take on the other hand, maybe a 45 or 50-year-old woman who's otherwise completely healthy, takes no medications. Her 10-year risk is probably 2 or 3% for having a heart attack or stroke, and a 20% relative risk reduction of that is a fraction of a percent. So same medication, same 20% relative risk reduction, but that just means a very different thing to different patients with different starting risks. And so drug companies love to use these techniques because 20%, 30% sounds like a lot, but if your total initial starting risk is low, that might not be so much. And that's why we tend to prefer to talk about absolute risk reductions, or at least I do.
Right. So the point there is that when we talk about risk, it's much more helpful in most cases anyway to talk about absolute risk rather than relative risk. And we doctors use a term called number needed to treat, which is one of the best ways to express absolute risk. So could you tell us what does number needed to treat mean and how do you use it?
Absolutely. So one of my favorite terms because of how relatable and understandable it is. How many people do I need to give a medication to in order to prevent one of the outcomes I'm trying to prevent? And I'll also add number needed to treat's close cousin, number needed to harm. How many people do I need to give a medication to until I'm very likely to get a side effect of that medication? And so let's run through a quick example with this one. Aspirin is a great example for this one. Aspirin is a mild blood thinner. It prevents heart attacks and strokes, but being a mild blood thinner, it also increases the likelihood of you having a bleeding event. And so it turns out that the number needed to treat and the number needed to harm for aspirin are almost the same. They're about 200 to 250. So if I treat 250 patients with a daily baby aspirin, I'm probably going to prevent one heart attack or stroke, and I'm probably going to cause one episode of bleeding. Now I'm going to take out a minute here to point out another sort of common pitfall. From what I presented above, you might think aspirin is a wash. Now, the problem is there's a wide range of outcomes, right? A heart attack can be very mild and not change your life much at all. A heart attack can also be fatal and devastating. Similarly, a bleeding event might wind you up in the hospital for a day and be unpleasant, but you get over it. And a bleeding event might be a bleeding event into your brain where you're catastrophically changed for the rest of your life. So, context is everything, but number needed to treat, number needed to harm are good corollaries of absolute risk reduction to really get a sense of how likely am I to benefit from this medication, how likely am I to get hurt by this medication.
Right. So the case you gave before of the statin, the cholesterol medication for a 70-year-old man, the number needed to treat may be something like 10 or 15, which is a relatively small number, whereas the younger woman, even though it's also a 30% relative risk reduction, the number needed to treat, number of women like her that would need to be treated with a statin might be several hundred to prevent one heart attack. So it's a very, very different thing. Context is also important when interpreting test results. And this is not an intuitive thing to understand, but the result of a test is actually affected by how common that condition is. Can you try to break that down for us?
So there's really two things we need to talk about to thoroughly interpret a test result. You need to know, first of all, how common a condition is, and then the second thing you need to know is how accurate your test is for diagnosing that condition. And so why are these things important? Because false positives and false negatives are happening all the time. Their tests are not perfect. And if you have a lot of people with a disease, the chance of false negatives goes up, and vice versa. We could have positive test results, but even if our sensitivity is good, there's going to be more false positives.
Okay, so what you're saying is that when you interpret a test, it's not a black and white thing, but rather you need to consider how common the condition is and how accurate your test is. And that's always counterintuitive to patients that a test is not always a black and white thing. And sometimes I just say a test helps us guides us, gives us a little more information, pushes us in one direction or another. When I hear someone's story, for example, I could say, oh, that sounds like a heart problem, and the test is positive, so that makes me even more confident it's a heart problem. But none of these things are definitive and black and white. And so, these nuances are why we doctors are still in business, I guess. Another tricky concept is overdiagnosis, which is diagnosing a condition that never otherwise would have caused a problem in the patient's lifetime. And again, this doesn't always sit well with patients, doesn't always seem intuitive. What can you explain to us what overdiagnosis is?
Absolutely. Well, our tests, they find a lot of stuff. And if you run a lot of tests, you're going to get some positive results back. But even if you do have a positive result, that's a true positive. So, the patient really does have the disease. Not all of these diseases are going to impact the lives of patients at all. And I think the most common one that we talk about is prostate cancer. It turns out that most frequently when patients have prostate cancer, there's that cancer living inside their prostate, and it's going to live there for 20, 30, 40, 50 years, and it's going to be something else that ends up taking the life of the patient, and they will die with prostate cancer, not of prostate cancer. And so when we go looking for things, we find things, but we don't necessarily find things that matter. And so I think you really need to think about what type of a patient you are when you get tests done, because if you're the type of patient who might find something and it might just make you totally crazy knowing that it's there, that's worth considering, because just knowing that there's prostate cancer in your prostate might, for a man, be unbearable to live with. But the reality might be that they would just go on living and never have known if we had never tested for it. And so overdiagnosis is something I worry a lot about. Another disease that I think we overdiagnose a lot is thyroid disease. Everybody is feeling a little bit tired. Everyone's hair is thinning and their nails are getting brittle as we get older. These are also signs of thyroid disease. And if we send screening thyroid tests, a lot of times the thyroid result comes back just a little bit out of range, and maybe their thyroid isn't perfect, but it's probably not causing their symptoms. And we end up doing a lot of work with people on their thyroids or fretting about prostate cancer when really the disease wouldn't have caused any trouble if we hadn't found it in the first place.
Well, one thing that really crystallized that concept of overdiagnosis to me is I've seen a couple studies over the years where they do autopsies on people who died from other reasons. So 70-year-old men who died in a car accident. And the autopsy shows that a large number of them have prostate cancer if you examine their prostate. And obviously, half of men do not die of prostate cancer. So that's one way that really crystallized it for me, that these cancers are just sitting there and never otherwise would have caused problems if they hadn't known about it. I've also felt sometimes that the terminology calling it a cancer isn't necessarily the right term. It's sort of a condition of unknown significance. We don't know whether it's going to progress or not. All right, so this is a lot of information, and so we'll keep this one of the shorter discussions because this is one of those conversations where there's only so much information you can take in at once. But I do have to ask you about data in the pandemic, because we've had so many numbers thrown at us and everyone interprets it differently and so forth. So let me rapid fire go through a couple pandemic related statistics. So first, in terms of testing, there was a real hope that testing everybody every day all the time was going to get us out of this pandemic. And that really has not proven to be the case. And I think part of the reason for that is actually a misunderstanding of statistics. So could you talk a little bit about that?
Yeah, well, I think the testing strategies that have been employed throughout the pandemic have sort of confused me from the beginning, because they certainly weren't in line with anything I learned in evidence-based medicine of either residency or medical school. Now, you can make the argument I was never in a pandemic during those times, but fundamentally, rapidly testing a huge number of asymptomatic people just to see if they have a disease, you just find a huge amount of disease that is clinically insignificant. And we also don't know how to deal with it. I mean, it's pure, I'm sure some of your listeners, when they hear me say this, are saying, well, being asymptomatic doesn't mean you can't spread it. Maybe it does, maybe it doesn't. I mean, we really don't know. But in my opinion, for many of the reasons we've discussed in this episode so far, these tests have caused, I would say, at least as much harm, if good. And I'm just not sure what surveillance testing has done really much good at all outside of, I'm sure there's certain circumstances where people were testing to get onto a movie set or to get into a wedding where maybe it makes a little bit more sense. But just the general, we're going to test people over and over to try to catch this disease, certainly not what I learned in medical school or residency.
Yeah, well, the test results certainly can be misleading. And some of the projections I've seen is that if you even tested everybody on a weekly basis, the impact that would have because of all these false positives and false negatives and delays and incubation periods and so forth is probably pretty modest, only a 10 to 20% reduction in spread. Not to say that that's nothing, but it's not a total game changer like some people have made it suggested it might be. So the other way where I think we've had a hard time interpreting statistics is with the impact of treatment. So I'm thinking of a couple of examples like remdesivir and dexamethasone, again, where we get numbers that this treatment reduces the risk of death by 30%, but yet we're not using it in everybody. We're only using it in certain narrow segments of the population. Help us understand what's going on there.
Yeah, this is something that I have a hard time, but I think a worthwhile time talking with my patients all the time through the pandemic. So these medications, it's always easier to show that a medication works in the sickest patients, okay? When bad outcomes like death or long-term disability are very common, it's easier to prevent a couple of them and to show a risk reduction. But just like we talked about for the statin medications, patients who are very sick have a pretty significant absolute risk reduction, and people who aren't very sick tend to not. And so here we have all these studies coming from the sickest patients in intensive care units, really struggling for their lives day to day. And then we find out that ivermectin or dexamethasone or something as working in ICUs, and suddenly my patients come to me with asymptomatic COVID or sniffles or maybe even a not so pleasant flu, but they're overall doing pretty well, and they want ivermectin or they want hydroxychloroquine or they want dexamethasone. And it's actually exactly the thing we talked about earlier with statin medications, where you might show some benefit with the sickest patients, but you probably are going to get a negligible, if any, true benefit in patients who don't have as much risk to start with. They're probably going to get better on their own with or without these medications. And the side effects we get from these medications may be worth it when there's a large absolute risk reduction in the sickest of sick patients. But the side effects we're going to get in patients who probably are going to get better on their own really just doesn't merit the use of these.
I think you said it well. When the number needed to treat is like 5 to 10, it very well may be worth the side effects of the medication. But if the number needed to treat is several hundred, the harms of the side effects may outweigh the benefits. So it's a really complex calculus.
It turns out when we look at these observational data and we test these claims of cause and effect, when we do randomize, confounders are causing a lot of what we're seeing in the observational data, and at least half, if not up to 70 or 80% of these data are just seeing confounders and not true cause and effect. And so I am always hesitant to call upon data in these observational settings that we want to apply very, very broadly. So just to mention that, and not to beat a dead horse, but I think vitamin D is another one I just want to toss in there. So, everyone sees these correlations of positive health with high vitamin D levels. Well, we know that vitamin D, you get that from being outside in the sunlight. And so is it really high vitamin D levels that lead to better health outcomes, or is it really that our patients who are getting out in the sunlight, exercising, running, walking, biking, have better cardiovascular outcomes? But everyone wants to just take a vitamin D pill and yield those results. And maybe the answer is just to get in the park and do a jog.
That's right. And a lot of times the actual rigorous studies have shown that a vitamin D pill causes as much harm as good. Well, let me throw in one last question for you. You treat a very interesting population of patients experiencing homelessness, who often, at the risk of stereotyping, have a lower education level, lower health literacy. How do you convey these concepts to a population like that?
Absolutely. So many of my patients bring a lot to the table. My patients have there's a lot of mental illness with fixed delusions and psychosis, and that can complicate things. There's also a lot of historical distrust in the medical community, which, if you've read about our history, is not unfounded, although I like to think happening a lot less now. And so the approach I take with my patients is very simple. I push the vaccine hard. After my last comment, you might not think so, but I push the vaccine hard. I want everyone to get vaccinated. I want to get through this pandemic. I want to move on. And I don't think COVID's ever going to be gone, but I want to get it to a place where we can get back to a normal. I welcome patients with open arms who do not want to be vaccinated, because those are the patients who need me the most. I say, I'm not going to kick you out of my practice. I'm not going to criticize you. I just want to give you all of the information that I have about the vaccine, and I want you to see that when you know what I know, that this is a good decision for you. And I like to think that sort of approach, which, by the way, that's how I approach all the care of my patients. My patients don't take my advice all the time for any number of reasons, and I just welcome them with open arms as long as they're willing to come see me. And I think, honestly, that fosters the trust in our doctor-patient relationship that lets me say to them, listen, this COVID vaccine, I know you're skeptical. I really trust it. I've given it to my family. I've given it to myself. I think it will be good for you. And a lot of them will take my word for it, because we've built that trusting relationship. And if not, it's about seeing them back. We're going to talk today. If they say no to it today, we talk about it again next month or in a couple months. And there are people who are never going to have their minds changed, but a lot of patients with time and attention eventually do.
And when you do mention terms like relative risk and number needed to treat and false positives, false negatives, do you feel that your population is able to understand that at some level?
I do think so. I mean, I try to keep numbers. I mean, listen, I alluded to this earlier in our talk. I don't think I know what 1 in a million means. I don't think many individual human beings understand what 1 in a million means. A million is just a number that's very large. And so I use the same numbers with my patients that I understand. I try to use number needed to treat. I try to say, there's 50 people in this clinic right now. If I gave the pill to everyone in this clinic, and one of them, if the number needed to treat is 50, one of them would get benefit. And so I do think so. I use a lot of drawings. I do a lot of pictures. I just sort of scribble on the paper to try to draw the pie chart, to do visual representations. Whatever it is to help patients understand the statistics, I really try to take advantage of. And sometimes it lands, sometimes it's just confused, quizzical looks. But I'm always just trying to convey the information in different ways for different learning styles. Being a doctor, a lot of times, is like being a teacher, and you're just trying to reach every kid in your class in the different ways. And some want to hear it in writing, and some want to see it as a picture, and some want to see it as a video, and maybe someone wants to hear it as a song, But I try to just keep it fresh and try to break it down into simple terms that people can understand. And I do think that most of my patients leave the room sort of understanding the risk for them.
Well, it's often said that medicine is as much art as it is science. And I think nowhere is this more true than with statistics. You can understand the science of it, the math of it, but you have to convey it in a way that your patients are going to understand it for it to be meaningful. So thank you, Stephen, Dr. Stephen Hochman, for helping us try to break it down today. If you did enjoy what you heard today, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it on to friends, family, and others who might be interested. Leave a review if you have a chance, and we will pick it up again next week. Thanks for joining me, Stephen.